afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the conference over to your moderator, Neil Driner, Director at CSHI. Please go ahead.
Hello, and thanks so much. Welcome to today's Priority Health Innovation Challenge webinar. My name is Neil Dreimer, and I'm so excited to be joining you today as the new host and director for the CSHI Challenges team, as my colleague Jennifer Thornhill-Verma has gone off on mat leave and is soon expecting twins any day now. I'd also like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous people since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. We also want to acknowledge, as many of you are of course aware, that this is an unprecedented time for us as individuals, but of course also in the healthcare system and around the world. We would like to take this time to thank all of you and our healthcare and essential workers who are working tirelessly to keep Canadians healthy at this time. We are pleased to host all Priority Health Challenge activities bilingually, including this webinar. If you wish to view today's slides in French, please let us know in the chat box now. The telephone number to connect to the French audio will be on the screen once you are transferred to the French room. We invite you to use either official language when entering your questions and comments in the chat box. So today we will be talking about a favorite topic of mine, using data for improvement. We know that this will be a useful webinar for all of you out there who are working in quality improvement, both in mental health and addictions, home and community care, and beyond. Before we get started, I do want to mention a few housekeeping items. First of all, if you haven't already done so, feel free to please take a moment to introduce yourself using the chat box, which you'll find on the bottom right-hand side of your screen. Feel free to tell us a little bit more about yourself, where you're calling from, which organization you work at, and any burning questions you might have for us today. We're also pleased to be providing simultaneous interpretation and a fully bilingual chat box for this webinar. Feel free at any time to please send in your questions using this chat box in either French or English. We have reserved some specific time at the end of the webinar to go through these questions, but feel free to chat them in as we go. It's now my pleasure to introduce today's featured speaker. Dr. Rylan Egan is an assistant professor with health quality programs at Queen's University. Rylan has expertise in qualitative, quantitative, and mixed method research. He co-developed the quality improvement curriculum and works locally, nationally, and internationally on healthcare quality initiatives. Today, Rylan will demonstrate why data matters in QI work and explore how you can collect and monitor the right data for your initiative. Welcome, Rylan. I'd also like to take the time to introduce my colleagues on the Challenges team, Lindsay, Sabrina, and Emily, who you'll find monitoring the chat box and who are your go-to people if you have any questions. So, which brings us to today in today's webinar. Why are we gathered here today? So you can see our webinar objectives on the screen. So first of all, as there are many new folks online, a warm welcome to you all. We do want to provide just a quick overview of the innovations at CSHI and take a look at where we are in our priority health journey, as well as celebrate our recent award winners. We'll also get a great opportunity to hear briefly from two of our participating teams who will focus on overcoming barriers to data collection and their learning. Feel free as well to start thinking about questions you might have for them. They are doing this work every day and like you have navigated challenges as well as great successes. And finally, we will be hearing from Dr. Rylan Egan. So just a very quick mention about the Canadian Foundation for Healthcare Improvement and where this work fits into our strategy. So finding and promoting innovators and innovations is one of the key goals that we do at CFHI together with partners, many of whom are on the call today. The Priority Health Innovation Challenges focuses on finding novel approaches to improving access to mental health and home and community care services. So on this slide, you'll see examples of access indicators that we're focusing on within the mental health and addiction services realm. So really what we're hoping is that many of the teams who are joining us in the challenges will share their novel approaches to how they're improving any of these shared health indicators in mental health and addiction services. As well, teams are also joining from the home and community care sector and looking to address any of these indicators such as caregiver distress. If you do have any questions about these indicators and how they came to be, feel free to reach out to the Challenges team. And our team will definitely share their email information in case you don't have it handy in the chat box. So where are we on our journey so far? So I'm really pleased to say that we're actually past the halfway mark within the Priority Health Innovation Challenge timelines, which right now the challenges are ending in October, so we're getting there and we're getting closer and we're really excited about how far we've come. On this slide here, you see a team map really illustrating where the different teams, both in mental health and home and community care, are coming from. Currently we have 21 Priority Health teams, including 8 working in home and community care and 13 working in the mental health space. This is also a great opportunity for us to reflect that we do have some new challenges teams. So in the home and community care sector, we'd like to extend a warm welcome to CHEO, the Children's Hospital of Eastern Ontario, and their focus on their family navigation project. And in the mental health and addiction space, we'd like to welcome the Peter Lougheed Hospital out of Calgary and their project, which is focusing on contingency management for stimulant use disorder, as well as the Pathstone Mental Health organization and their project, which is focusing on violence threat risk assessment care pathway. So welcome to all 3 of you. Speaking of teams, we also wanted to take a moment to highlight our midterm challenge winning teams who are able to demonstrate improvement through their data and won a combined amount of $55,000 to further support spreading and scaling their work. The winners were Vancouver Coastal Health, the Canadian Mental Health Association York Region, Sunnybrook Health Sciences Centre, and the Calgary Foothills Primary Care Network. As well, we also wanted to celebrate our recent mini challenge number 2 winning teams. The focus of that award was on their project improvement charters, which focused on the current status of their project. Together, they won a combined amount of $35,000 to support their work. And you can see the winners on the screen. Edmonton zone and Calgary zone out of Alberta Health Services, the Calgary Foothills Primary Care Network, the Home Ventilation Program out of CHEO in Ottawa, McGill University Health Sciences Center, Sunnybrook, and Pathstone Mental Health. So congratulations to you all. So I think enough of me talking. Now it's my distinct pleasure to turn it over to two of the Challenges teams themselves and to better understand how they're using their data to further support their work. And again, I encourage folks, as you're listening to these, to our two speakers, to chat in any questions that you might have. And I can see that the chat box is getting busy with just introductions, which is great to hear. So with that, I'll now turn it over to Karen Lung at CMHA York, and who'll be talking a little bit more about the Bounce Back program. So Karen, over to you, and I believe we'll be advancing your slide.
Hi there. Thank you so much for this opportunity to speak about data as it respects to Bounce Back. I'm really excited to be here, and this is just such an unprecedented time, as you mentioned, and it's a wonderful opportunity to be able to speak to everybody across the country. So this is a really exciting opportunity. Thank you. So in terms of overcoming barriers in data collection, there's so much to speak to when it comes to this topic, but I did do some reflection as to what were some key areas of success when it comes to our program and how we've been able to overcome barriers when it comes to data collection. So from my perspective and from our team's perspective, really we found that developing a data-friendly culture is really so crucial to data collection and using a quality improvement approach. And so we found that many individuals on the front line, they're very focused, obviously, to focus on providing great care for their patients and participants. And they find that data to be cumbersome. They find it to be an administrative burden. It can be scary to many people, as if they feel like it's becoming a barrier, as well as something that they don't truly understand. They don't understand why it needs to be done, and they want to focus on providing the care. And so we really focused on creating this culture where we actually have the staff very much involved in the development of the training and implementation of data collection. And the data-friendly component of it is to encourage individuals to really understand the why behind what they're doing in terms of data collection, and that it's not something simply that's done for the sake of collecting information because somebody out there wants that information. Make it very clear to the staff, and we involve them in determining key ways that they're able to collect and contribute to a better understanding of what's happening in terms of wait time, specifically for our project. So we found that to be very important, and also in terms of the data collection, data-friendly culture, another key part of the quality improvement approach is ensuring that folks are eager to understand that the data collection is not one that is actually at the research level. And I think there needs to be an understanding that there's a difference between research data and quality improvement data, because some individuals can get very caught up into perfect data, and needing it to be down to the level of having so much detail to the data that they want to collect, and needing to understand that quality improvement has a very different perspective. Of course, we want accurate data. Of course, we want to have fulsome data, but there is a difference between research and quality improvement. And so I think having a little bit of education as well for our frontline staff with respect to that difference is really helpful, because I guess the journey was for our staff is that they got, we got folks really excited about data. They were, they had a contribution to developing the training and the implementation of the data, the collection processes, and then they got to a point where they're like, oh, but what about this? We could also include, collect this information, and what about this? And wouldn't it be interesting? So they kind of got that data collection, bug. They kind of caught that bug and excitement, and then they kind of went another way where it was they wanted to collect a lot of information and perhaps a little bit too much. So it was an interesting journey for our group, and through education as well as building culture, we've been developing a great culture and a lot of excitement around data collection. And then finally, I would say that it was really important for our frontline staff to be able to provide some feedback on the data that they collected, so that they can see and understand why it was that we were asking them to spend time to collect information in an accurate way, and also to understand when we make changes. Why is it that we were collecting, certain pieces of information, and now we're asking them to collect something else? So it was very important to get them on board and to get that buy-in, to understand all the different changes that we were making in order that we have the information that we have, and we can analyze and understand what was happening with our wait times, and in order to implement change ideas to ultimately improve our wait times. So those were some of our key highlights from overcoming our barriers in data collection, and happy to respond to any questions at the end of the presentation if there's time.
Thanks so much, Karen. And I could, just listening to you speak, and you brought up so many important points, and I imagine Rylan is going to be addressing some of those, really getting a sense of the difference between QI and research data, understanding the why, and getting people excited about data, I think are really pivotal points. So thanks for sharing your presentation and your thoughts, and feel free, folks, to continue to use the chat box if there's any questions about Karen's presentation, and we'll get to those later on. It's now my pleasure to turn the mic over to Dr. Francois Bota from the Vancouver Coastal Health Authority and Kelty's Key team. So Francois, over to you.
Hello everyone. So first I'd just to start by thanking everyone here for the opportunity to contribute to this webinar. This is an area that's really key to what we do, the idea of data collection, analysis, and communication. And just to give a bit of background in terms of who we are. So Kelty's Key is essentially a team within the Vancouver Coastal Health region that focuses on promoting online therapy, and especially doing therapy through therapeutic email. We also have a website, keltyskey.com, that contains a number of treatments, for example, for depression, anxiety, and other mental health concerns. And so really in this idea of data and looking at wait times, when we got started, we were located within the outpatient services department. And really it was all about starting at home, and that is getting some reporting consistency going within that department and standardizing the processes. So you really had to start getting a sense of what was the client journey. How did they come in, let's say, to get services? Where was the delays happening? So being able to map out the client journey, being able to put some numbers to that, that allowed us to see where are the opportunities for improving access, where is the capacity there to really improve the client's experience as they were going through this process. So, for example, things that we did there, there was a screening process, an orientation process. We ended up combining some of that. We looked at getting clients in touch with the therapist they're going to be working with as quickly as possible so they did not have to have multiple contacts, and the coordination in terms of having to call someone, make a time, be synchronous at the same time, same place, and that cut off a lot of those concerns. What this allowed us to do really is to get us a bit of a sense of what the best practices were in terms of reducing wait times and in terms of delivery of online therapy. So that allowed us to kind of start creating some guides, some tools that we combined into like a brief operational manual, and we've been able to communicate that to other teams that have been looking to adopt online therapy within Vancouver Coastal Health. The second we started doing that, though, that made us realize that we've got to understand how different health areas deliver their service and what weight this means. And so everyone, can I say, in terms of the different areas we work in, that would be Vancouver, Richmond, Sea to Sky area, everyone has a slightly different way that they, the client intake, slightly different way in which clients enter different services. So while some might have been very particularly, you get assigned to a particular service, you begin, you end over a certain period of time. Others were much more open in terms of a client would be taken on and they might move through a different number of services, including online therapy. So really we had to spend a lot of time there walking through their processes, working closely with their administrative staff, working closely with their therapists to really understand if we are going to be comparing numbers, if we're going to be looking to reduce wait times, what would that particularly look like for each of those different areas. Another part that we started looking at is in terms of, we first gathered a lot of this manually, and so really starting to look how much we could automate that. And so we were kind of looking at our EMR system, how different things were recorded, what kind of data gets extracted from there, and that allowed us, can I say, to be much quicker and not necessarily have to have so much communication and to and fro exchange of information, as long as we could standardize how people recorded online therapy within the EMR system. So that was really kind of so that things in terms of barriers and just the data collection side of it. When we were looking at kind of really using this data to illustrate what our impact was, firstly, we were looking at this idea of spread and scale. That's to say, getting other teams within Vancouver Coastal Health to also adopt online therapy. And so here really we were first able to identify what were some of the gaps in terms of service delivery. We kind of saw that what kind of individuals, what type of clients was really interested in online therapy. And so we were to identify people who had postpartum depression, postpartum anxiety. It was very popular with them. People who did shift work, people who traveled a lot, people who had physical concerns that may be difficult for them to really commit to be at a particular point at a particular time. So we were really able to see who we can best promote this to. It also allowed us to communicate that you can have, improved efficiencies in terms of how much therapist time is used. So we tracked how much time each therapist was spending in doing therapy, and being able to share that these are similar outcomes to what people were kind of used to. So kind of really looking at this idea of what do people find important, what do therapists find important, etc. So three main things I just wanted to share in terms of what we learned and that I felt was really important. And the first thing was just that relationship to relationship. That's absolutely the key part. And that is on all of it. That would be, with management, with the executive, with administrative staff, with therapists. Really, it was so important to build trust over time. Be open, be available, let people want to talk to you. in that sense. And just when issues came up, etc., there's a good relations. It made it all just so much easier to resolve and to work through. Part of that was also understanding what was success for the different stakeholders, what the clients really want, what the therapists want to see, what the management want to see, what the executives want to see. An example of that may be that on an executive level, a really big piece became this idea of how much does doing online therapy actually prevent hospitalization and use of the emergency room. So kind of this idea of knowing what are the key statistics, what the key ideas that all the different stakeholders should be looking for. And just the final piece was just realizing that, the change process is something that really takes a lot of time. So we soon learned not to overpromise, be realistic about what's happening, and also be aware of what pieces, we control, and what pieces are really outside of our control. And we can influence, but cannot affect change. Thank you.
Thank you so much, Dr. Botha. And I mean, I think what you shared is key to using data, but also to quality improvement and innovation in general. Yeah, building those relationships, really having a clear understanding what success looks like from the point of view of different stakeholders, and also taking into account how much time change really takes. So I really appreciate your thoughts and your firsthand experiences with this. So again, I just encourage anybody who has questions for Dr. Botha to chat them into the chat box, and we'll get to those a little bit later. With that, I think what you're seeing right now on the slide is just some of the answers and to some of our initial polling questions. So if you didn't have a chance to enter them in when you first came in, there's still an opportunity to do so in the chat box. So the first one was, what questions do we have about using data for improvement? So much has changed with caregiving in this COVID-19 pandemic. Caregivers' workload has increased significantly because of health services reorganization. So, I mean, I'm guessing that there is a question in that comment there. How do you really look at the impact of the COVID-19 pandemic on health services, and also with respect to caregivers per se and their workload? So feel free to chat that into the chat box if I didn't get that correct. And also just what would you like to take away from today's webinar? I will effectively use data, and I think we have the right person to address that coming right up. So, I'm sure Dr. Egan will keep that in mind as he goes through his presentation. And again, feel free to chat in your questions as he's speaking. So with that, I think we'll now pass the baton over to Rylan, and we'll let you move your slides. Welcome, Rylan.
Wonderful. Thank you so much, Neil, and thank you to the Canadian Foundation for Healthcare Improvement for having me. It's an absolutely an honor to talk to you about data. I like data, and I look forward to hopefully providing some suggestions and advice, but likely as importantly, providing some reasonable answers to questions and having a discussion. So thank you again, Neil, for that lovely introduction, both there and previously. And it's funny, one of the first questions is how to effectively use data, and I think both Karen and Francois gave some great advice just to that very point. And a couple of things just to quickly reiterate is, getting excited about data. Lots of people feel afraid or hesitant with data, but if you can get excited about it, as Francois said, in terms of relationships, it can actually really build relationships and put glue to the group where people are looking at the same information about success and challenges and coming up with solutions, and also celebrating successes. And another sage piece of advice that Karen provided was to really think of the difference between research and QI data. Both have their place and can be very valuable, but they're not the same as she suggested. Okay, so let's jump right in. So the first slide will seem a little out of place, and it'll be very much about, how does this have to do with data? But I'm going to suggest today as sort of a hypothesis or as sort of my contention that data is the tracks that the QI train runs on. It's a grounding force. It provides direction. You can move data and work with data, but it's the kind of thing that keeps you grounded and lets you know where you're going. And I'll also suggest that data in QI is valuable to the extent that it's informative and contextualized to your team. So throughout, I'm going to try and contextualize the use of data and talk about it in a contextualized way. I've even used one of the projects I saw as a baseline, so I've kind of put my some of the ideas into that case. However, it is all made up. I know nothing of substance about the case, and it's just to try and make it contextual, but not to be factually accurate. One of the things I think before we get into data per se is, thinking about unconscious bias, and Ruth Bader Ginsburg said, I think unconscious bias is one of the hardest things to get at. And when we work in QI, there's all kinds of biases we deal with, and that's not a slander to any particular person or a particular profession. We all do it. It's just the way we think. So data can help us check those biases and understand them. So for example, we don't remember, we recreate thought. So every time you think about something, you recreate it. And in that, we edit and reinforce some memories and discard others. We also tend to think we know what other people are thinking and what they want, and humans are some of the only animals that can do that to any extent, but we're overconfident and we tend to attribute flaws to other people as implicit characteristics and flaws to ourselves as unavoidable external factors. We selectively filter information that confirms our perspectives, and actually, if our memory is primed, we can see something but not perceive it. So you'll see a selective attention biases. Some of you have seen passing those activities where you watch people pass a basketball and count how many times it goes, and then a gorilla runs out on screens and waves its arms and you actually don't see it. So I say all of this to get to the fact that in QI, data is meant to be the railing or the guidance to your project. It's not meant to be there, as Karen suggested, as a way to have definitive proof that you've done the right thing or you've made great change. And there's some way you can use run charts and control charts to have statistical inference, but it's not the key point of QI data. Let me just get oriented here. Okay. So I'm going to really concentrate on three measures today: outcome measures, process measures, and balancing measures. And I imagine you've heard them all, and for some of you this will be a review, and some of you may be struggling with some of these measures. I think outcome measures are the most conceptually obvious. That's what you're trying to change, right? So if you're trying to decrease the rate of newly reported STIs, that's, you can count that, and it's what you're trying to achieve, and it's one of those first things you can measure. Process measures can be a little bit more confusing, because this is when you're measuring the thing you're doing to change the outcome. So, for example, if you're trying to understand or figure out the number of injuries due to falls in older adults, well, the process measure might be the program you've put in place for referral to decrease the rate of falls. And you can actually count that, right? So you can count the number of referrals. And that's a way to actually quantitatively measure the thing you're doing to make the change, which has a couple of benefits. And we'll talk about this more later, but it gets the team on board to see, okay, what are we measuring? Because importance usually comes with measurement. What are we measuring and what are we doing to make the change we hope to see? And how does the rate of referrals interact with the rate of falls. And you can look at that on charts, and we'll talk about that in a second. The one that I think people have the most problems with or get most confused with is balancing measures. Now, balancing measures have a lot in common with outcome measures. So outcome measures is the thing you want to change through doing your intervention. Balancing measures refer to the things that change that were not necessarily the intent of your process or what your intervention. So a simple one to think about can be money, right? So you're trying to, say, decrease the number of injuries due to falls. But you could look at the cost of your intervention and then look at the cost of falls and see if you've actually saved money. That's always a great thing. Or if it's cost a lot of money. In terms of the STI cases, you could look at staff satisfaction, right? So maybe the rate of newly reported STIs has decreased, but whatever you've done has really decreased staff satisfaction. So a balancing measure is just making sure that you're capturing the good benefit, the benefits or the unintended benefits of your outcome or your project, but also the unintended consequences of your project. So why should I collect data? And as I said, I like to contextualize. So I have killed a metaphor for your viewing pleasure with the hope of going through the different types of measures in a way that's more sort of conceptually obvious. So why should I collect data? Well, one's the facilitator. So you can look at the common saying or platitude that you can't fatten a pig by weighing it. And what a lot of people who are adverse to data will say is, look, I know what I'm doing. I know the problem. I know what causes it. I need to just get down, our team needs to get down to fixing this thing. And, you know, if we collect all this data, then we're going to not have time to actually make the change that we want to see. So I would suggest that sort of the retort or the auxiliary to that is, but we sell pigs by weight. So yes, you know, you can't fatten it by weighing it, but if you don't know what it weighs, you're going to have a hard time selling it and determining whether or not, you know, you're meeting your goal. And we make money by selling for more than our cost. So, you know, you want to be able to measure what it's costing you to fatten the pig. So yes, what's the weight? That's our outcome variable. But our process measure is, okay, but what's it costing us in feed and in other things we're doing to change the weight? And you're going to make sure that the cost of feeding the pig doesn't outweigh the cost or the money you're going to get for selling it. So one of the inferences, so we now have the outcome and process measure, right? We say, okay, we'll wait, and then the cost of feeding it. And so you say, well, all we have to do now is do what costs less and pays more, so we can maximize our income. But this gets to the balancing measure. Well, yeah, but what about humane treatment? And does that matter? And so humane treatment is your balancing measure. In this way, you're not trying to, humane treatment isn't the point of raising pigs to sell them, but it is something that matters. And if you're not measuring it in your efforts to decrease cost and increase income, you may not be being humane. So just try to put that in context for you. I should also say that, you know, if you'd like to interrupt at any time, if there's a question that you think would be better answered now, I'm not adverse at all to being interrupted or having that conversation, and I'll try and make sure there's some time at the end as well. Okay, so now we're going to look at an aim statement, and my guess is many of you have seen an aim statement, but it's good because it contextualizes your outcome measure, and it's really about the outcome measure. So in this case, falls is our outcome measure, the number of falls, and you write it into a statement. So falls will decrease at the alternative care unit in Faithful Hospital by 70%. And then you say you have to give a time frame between April 2020 and September 2020. So one of the things, the data involved in this, the 70% and your outcome measure, the falls, is it can promote hard questions. And when you're leading a team, having that data and that goal gives you the opportunity to ask those questions and have those discussions that if you just jump right into your project, you might miss. So for example, do we have baseline data? And do we have baseline data for the same time period or with the same staff members, or whatever might increase or decrease the risk of falls. So there's baseline data that's contextually similar. What is the time frame we're looking at? And because you have to write that in statement, that conversation has to happen, right? What is a reasonable time period? Makes you think about, well, when do most falls occur? So if we're going to try and decrease that number of falls, then we want to sort of get the low-hanging fruit and figure out when it occurs, and that gets into your contributing factors. Another thing is defining your data. So, you know, you don't need great data, and you don't necessarily need a lot of data, but consistent data is important. So, you know, if somebody's just starting to get up and falls back on their bum onto the bed, is that fall? If somebody's walking and they go to fall and they get caught, do we want to count that? Well, it's certainly a danger, but is it a fall? And if some people are counting it and some people aren't, then your data is going to get messed up. So we're going to talk a little bit about that. How are you going to make sure that you're consistent and you're not losing data if it's a near miss and not the actual outcome that you're trying to understand? But one of the key principles that I think both Karen and Francois talked about was this principle of parsimony, right? You want quality data, and if we were robots and machines and we could process millions of gigabits in a second, we'd want as much data as we could, but we're not. So you're really always balancing the quality of the data, and I should say the quantity of the data, and the resources and time spent in collecting and analyzing the data. And you have to find that sweet spot for you. I think it's fair to say that no data is dangerous, but I'd also say too much is overwhelming and confusing, and you can really demotivate your group and make it not very effective. So some sort of key principles in collecting data. Start small. Collect a little bit of data. And as you'll see at the bottom here, you're ensuring data consistency, you're recording errors, you're auditing your data to look for mistakes, but you're better to find those mistakes and errors and efficiencies in collection with a little bit. So say you're doing a chart review, do 15 first and get the kinks ironed out, and then go a little bit more and a little bit more and see where the errors are occurring. And then also say, well, how much time is it costing to do this? And is it going to be a sort of a insurmountable burden in terms of time, so you're not overwhelming individuals? Another question that always comes up is, when do I use data? And I suggest that data should be collected and considered throughout. You know, you have your intervention using plan, do, study, act cycles, and you have your problem and aim and your intervention. Data really lets the two move together, and if you don't have that cog, sometimes your PDSA can be spinning and you still see the aim, but you're not connecting the two. So prior to the intervention development, you know, you want to look at contributing factors. When things go wrong, you want to identify who's there, what's happened, and see if you can figure out what are the key things that are happening that are causing your problem. That'll help you develop your intervention. You want your baseline data. And you want to look at baseline, if appropriate, for outcome, balance, and process measures. And you might even want qualitative data. One of the questions that I think may have came up is, how do we, interweave qualitative data into all this? Well, you know, talking to people or interviews, qualitative data is really good at understanding a phenomenon, understanding what's going on. And then usually once you have your intervention, you see if you have an impact. That's where the quantitative data can come in more effectively. During the plan stage, you're going to try collecting the data and see what happens, see how much time. I just sort of said that. See how much time it's going to take and how valuable the data is. Maybe you're shopping the data around to say, is this telling us what we want? And you're calibrating, right? Are we all collecting the data in the same way? We've talked about kind of balanced process measures in the do and study phase, and then in the act, you go right back to prior intervention development, and you're looking at all those again. Okay. So I've done this work example, and again, this is not factual data, nor is it any judgment or anything like that, just a way to contextualize. So so the first question is, for the outcome measures, how will our area be different if this is successful, this intervention is successful? Well, that's going to be your outcome measure, and it's often a high-level indicator that is somewhat controllable. So, for example, during COVID, you're doing outreach community health support and you can't go in, you're not going to want to keep measuring that because it's not controllable for you right now. You want to ensure ahead of time that stakeholders agree that the outcome measure is a good representative of your purpose. So maybe you're in one profession in an interprofessional team and you say, this is what we need to measure to see how well we're doing. But then another profession or another stakeholder says, well, actually, that doesn't really get the whole picture. You should measure something else. And the act of or the opportunity to have that conversation is immensely valuable. And then is it feasible? So the program I quickly looked at had 3 key sort of interventions. So they referred, this was in terms of caregivers involved in an enhanced palliative program. And so for the caregivers, referral to appropriate services is one thing, caregiver support needs assessment, so seeing basically needs analysis or needs assessment. And then providing some tools, some self-management approach tools in a comprehensive suite. I hope I got that right. Well, an outcome measure could be time off work. You could say maybe measuring how much time off work would be a good indication of the sort of effectiveness of these interventions. Now you're going to shop that around and you say, well, time off work, that's not holidays, right? So you're going to work that. But the questions you're going to ask your team and the opportunity for collaboration is, do we have a data collection plan? Are we going to be able to connect the interventions, those interventions, to the outcome, or is there all kinds of other things that are going to impact time off work that have nothing to do with our interventions? And if so, you might try and tweak your outcome measure. Okay, so then we move to the process measure. The question is, how will you measure what you're doing? And it's often specific input measures, so the things you're doing based on the intervention. You're going to be trying to balance data accuracy and feasibility of collection. Can you get the data in a timely fashion, right? So if your process measures take 5 months to get the data back, it's probably not going to really inform your action. And again, in QI, your data is always there to inform your action. You need to carefully define data parameters and interpretation. So you're collecting the data the same way, and the group and even your stakeholders are understanding the data in the same way. So for example, the types of process measures could be referrals, CSI, that psychometric for that needs assessment, support, and maybe connections with support. And the questions that your team can get together is like, how will we get this data? Which of this data is most important? Can team members play a role in providing this data? What do we mean by appropriate? So we want appropriate referrals. Well, how are we going to figure out what that is, and how do we define that? Is it feasible to determine appropriateness regularly? Like, is that something we can do really easily, or is it more difficult, etc.? So then finally, getting to the balancing measures, what are the unintended consequences of your project, right? So data related to the outcome, but not the focus of the project. So you're going to consider positive and negative consequences, choose carefully, strategically, as possibilities are likely endless. If you're trying to measure potential impacts of your project that you don't intend, and you start brainstorming, there's infinite possibilities. So really pick what are the key ones we really want to know. Often money is important, as we talked about, and you want to keep patient safety in the forefront. And if you can keep a balancing measure around that, that's important. So examples again for our interventions, maybe cost of implementation, time engaging in support, practitioner confidentiality. These could be all things we want to consider about. And can we do a costing analysis to show overall savings or no material cost? And another example question is patient care impacted negatively by practitioners' time to engage in intervention, or maybe positively by less time off work? I said we were going to quickly talk about charting. So I've created a basic run chart. I haven't even made this a control chart. We're not going to get any of the statistics involved. But just something just to sort of look at your data and try and understand and think about how this can guide your project. So you're looking at your baseline, and this is the non-vacation days off, so we've qualified that a little bit, not just days off, but non-vacation days off. And we see we have a fairly erratic process. It could be a seasonal effect in terms of a dip. And then we annotate the things. So we know where it's baseline, we know where the intervention started, and we see there's a little bit of an increase after the intervention started, and that's common. So when you start a new intervention, often the thing you're trying to decrease increases. But then over time, there's a drop, which is good. And we see there's an inverse relationship between the number of appropriate referrals and the time off work dropping. The appropriate CSIs are going up as you'd expect. But then often you can say, well, oh my God, our appropriate referrals dropped. Well, you only need so many maybe, and maybe things are getting better, so less referrals are needed, and same with the psychometric test. And then you might see something like this rise in non-vacation days off at the end. You should be juxtaposing that to that time last year, right? So at the start in January, February last year, it actually went up quite high. And yes, it's going up a little bit earlier, but again, it also went up in the 10th and 11th months, which is about the same time as the 23rd and 24th. So yes, it's going up, but it's quite a bit lower than last year. And it's that conversation you can have with your group and with your stakeholders as you go along with data, and that can be really helpful. And then I do want to take a little bit of time for questions, so I'll just show one more, and this is your cost benefit, the net cost of the intervention. So you take the cost of your intervention and the money savings, this time probably time off work. And this chart, if you're trying to sustain your project, even though it takes a little bit of time and effort to do, if you can show what you're doing just isn't an output by the organization, but it's actually a way to save money, it can often be favorably accepted. So that's all I really want to say. Again, thank you so much for your attention. I hope that was somewhat useful, and happy to take questions and engage in conversation. So back to you, Neil.
Thanks so much, Rylan. And we do, you reflected so many important comments there, and I jotted a few down. Data is the radar, but it doesn't provide definitive proof, really reflecting on the difference between data for QI versus research and the idea of having some consistency. So we have time for a few questions. I see one that's already been chatted in, and I think it's top of mind for many people these days. So Sharon from the University of Alberta just reflected, it would be hard to measure the impact of our home care program right now on caregiver distress. There's been too much change because of COVID. So I guess the crux of that question is, when an external event or variable impacts your data, how do you still measure the impact of your intervention? Any thoughts on that, Ryan?
Yeah, there's no, for me, there's no silver bullets in that sense. One of the things you can do is annotate. I don't think any of us will forget COVID anytime soon, but there are things that happen. So if you have a big gap in your data, or you have a spike, if you use like little black boxes like I think you still see on your screen to annotate, it'll remind you what happened. And so if you have a gap in your data or an unexpected spike, well, maybe something happened that wasn't in your control. And again, that's a way to communicate. And everybody will know when COVID happened, but people wouldn't potentially remember when there was an accident area and there was a surge in the ER. You might forget about that when you look back at it by annotating and showing it, but in terms of what do you do when you're overworked and it's really going to be impossible to collect data, I certainly think safety and community health is more important than data, even though I think data is very important.
Yeah, no, the importance of visualization and run charts, I think, can't be overstated to help tell the story. And I think Sharon just added that. I guess in the context It's been stated that COVID-19 has added about 10 hours per week to caregivers' work. Just more context there. I guess just a question that we also were thinking is, so how often should you be looking at your data collection plans and the data? Like, what do you have a recommendation? If I know some people collect the data and look at it 6 months later. Is it, any recommendations on frequency of looking at your data for QI?
Yeah, well, I would say, and this might be a bit of a truism, but, the more frequently and the closer to the event, the better, right? Because anytime, again, COVID's been around, but testing, right? That the sooner you know when something happens, the more agile you are in reacting to it. But as usual, that has to be balanced with feasibility. Now, you can also collect things at different times or at different intervals. So, for example, you might be looking in this little example, time off work on a weekly basis, but the number of, CSI, like the psychometric, maybe that's not as important. I'm not saying it isn't, but maybe it isn't. So maybe you're collecting that on a monthly basis. So you're balancing constantly how much time is it to collect, how valuable is it, and if you can pick 2 things that you're collecting sort of on a weekly basis, and then you're sort of looking retrospectively at 2 or 3 more that are important but not as sort of immediately crucial, then that can be a good strategy. But clearly, the sooner you can get the information, the more quickly you can react to it.
Well, thanks so much, Rylan. I think we're almost at time, so I encourage folks, if you have other questions, continue to put them in the chat box, and we can see if we can email them back to Rylan if there are any that come to mind. But so thanks again, Rylan. We really do appreciate your presentation and all our presenters today. I do want to remind folks that our next scheduled webinar is June 17th at noon, and the focus there will be on rapid innovations, lessons from a crisis. And just related to that, if you have developed rapid innovations in the time of pandemic, we'd love to hear from you. They can be policies, tools, resources, just ways of communicating or new ways of working. We'd love to hear them, so feel free to email our Challenges team. Once again, I want to make sure we say thank you to Dr. Egan, Karen, and Dr. Botha for everything they've shared today. And to thank you to the Challenges team at CSHI, Lindsay, Sabrina, Emily, and of course our producers who are working behind the scenes to make sure this is as seamless as possible. And finally, we want to say thanks to all of you today for taking the time. We know it's busy, and for your enthusiasm, feedback, and great questions and insights. So just before you log off, we just ask you to complete the feedback polls that you'll be seeing now on the screen, and they will be helpful in informing future award and webinar opportunities. Once again, thanks all for joining, and have a great long weekend.
Thank you, everybody. Have a great time. Thank you very much.
This concludes today's conference. Thank you for your participation. You may now disconnect.